Hello, everybody, and happy Friday. My name is Sabrina Corlett, and I am a research professor and co-director of the Center on Health Insurance Reforms at the Georgetown University McCourt School of Public Policy. I'll be your moderator today as we try to untangle the complex web that is our healthcare system. I'm really looking forward to today's discussion, which concludes our two-part webinar series. If you missed our first webinar, the recording is available on our YouTube channel, and we will drop that link into the chat momentarily. For those of you not familiar with CHIR, we are a team of experts on health coverage and healthcare markets. We study the interplay of state and federal policies that affect how people access and use healthcare services. Before we begin, I want to thank the sponsors of today's event, Arnold Ventures, and go over a few quick logistics. First, this webinar is being recorded. Everyone will receive an email early next week with a link to the recording. The recording will also be posted to our website. Second, we welcome you to use the chat to introduce yourselves, share reactions, and connect. And if you have any technical issues, drop those into the chat too, and our producer, Katie Sargent, will do her best to help you. Finally, this is a discussion, and while we will be asking our guests some questions, we hope you also will submit questions for our speakers. You can drop those questions into the Q&A box, which is at the bottom of your screen. We'll do our best to respond to as many questions as we can. Now that we've covered those details, I am delighted to introduce today's fabulous speakers. We'll first hear from Dr. Linda Blumberg. Linda is a research professor at CHIR and an expert on health insurance, healthcare financing, and health system reform. Her recent groundbreaking work identifying and breaking down the complex web of healthcare financial interests in the US today has helped shine a light on how profit maximizing actors in our system are impacting what we pay for healthcare. We will then hear from Karen Davenport, a senior research fellow at CHIR. She has been leading our center's efforts to document and monitor efforts to rein in hospital monopolies and anti-competitive behavior across the 50 states. And we'll share some of the exciting and innovative approaches that states are using to tackle the complex web. We will then get to drill down with two incredible state leaders. Dr. Gloria Sachdev of the Indiana Department of Health and Family Services is a pharmacist and health policy expert. Prior to her appointment as secretary, she became nationally known as the president and CEO of the Employers Forum of Indiana, where she championed numerous policies, many of which have been enacted to reduce healthcare costs. And we were also honored to have Meg Garratt-Reed, executive director of the Maine Office of Affordable Healthcare, an independent state agency tasked with analyzing the drivers of healthcare costs and proposing policy solutions to improve Maine's healthcare system. Today's conversation could not be more timely. As Linda, Chris Hamby, and Amy Goldstein documented so well in our first webinar, costs are rising due to increased consolidation, the incursion of private equity, and complex financial interactions among payers, providers, and a myriad of middlemen who prioritize profits over patient care. And as we heard from polling expert Jesse Klein, voters are now ranking healthcare above utilities, housing, and groceries as their biggest cost concern. Elected officials across the country are hearing from their constituents and weighing how to preserve healthcare access and quality, increase affordability, and keep healthcare financially sustainable. In this second of our two-part series, we hope to give you policy pathways that policymakers can take to foster a healthy healthcare market and hold industry actors accountable when they give consumers a raw deal. I am so excited to hear from these terrific speakers today. I'll hand it over to Linda now.
Thank you so much, Sabrina, and good afternoon, everyone, and thank you for joining us for today's webinar. For those who are joining us for the first time, and for everyone else who could use a quick recap, I'll just take a couple of minutes to review the problem that we believe is critical for the nation to address. Next slide, please. This figure, which is taken from our paper that's available online, provides just a small sampling of the intertwined financial relationships that now characterize our healthcare system and connect providers, insurers, and TPAs with a new breed of administrative and financial middlemen. These relationships are sometimes comprised of jointly owned entities, but they are often made up of mutually advantageous financial deals between otherwise unaffiliated entities. These intertwined relationships mean that none of the stakeholders have an interest in holding down healthcare spending. The incentives consistently lead to higher prices and a higher overall spend. The opaque nature of these relationships mean that most consumers and employers are unaware of the conflicts of interest and hidden fees inherent in them, and they are basically unregulated. Even those employers who have come to understand the nature of what they're dealing with when providing health benefits to their workers find their hands tied, since they don't see alternatives outside the web. If costs are allowed to continue accelerating under this dynamic, affordability and access to care will continue to worsen. Next slide, please. So let's start by establishing some first principles for any effective policy approach. The problems we face are systemic, and so effective solutions will need to be systemic as well. The financial relationships of these stakeholders are so extensively intertwined that it's extremely unlikely that any small change will result in a noticeable impact on overall spending. If we prohibit or interfere with any isolated fee or a small number of provider prices, stakeholders can be expected to nimbly respond with a new fee or a price increase on a different service to compensate. Think of it as putting a single boulder in the midst of a rushing stream. This is bad news, of course, for a political system that has challenges with even incremental changes, but it's critical to our understanding of what effective policy strategies would look like. Next, please. So now let's move to an overview of our suggested three-pronged framework. First, we need a requirement that rational prices be paid to healthcare providers in the commercial market, along with other related policies and protections. You'll note that I'm focusing on commercial market prices here because our public insurance programs already limit prices paid to providers on behalf of public program enrollees, yet prices paid by commercial insurers and the uninsured are increasingly a function of stakeholder market power, much more than they are of input costs associated with providing a given service. Second, we'll need an array of policies that prohibit the problematic financial relationships between stakeholders, including insurers, providers, and middlemen, that have corrupted the system and separated profitability from the provision of quality medical services. And third, we'll need a set of policies that prohibit the problematic financial extraction practices commonly used in private equity deals that lead to higher prices, lower quality, and even provider financial instability. You'll notice I'm talking about prohibiting the practices, not the type of ownership, since any type of business can take on these problematic practices. They're not limited to private equity, and not every private equity firm necessarily undertakes them. Next slide, please. So let's start with a bit of a deeper dive into the policies I'm talking about surrounding rationalization of provider pricing, our first category. First and foremost, in this group of policies, we need to limit provider prices, broadly speaking, and eliminate incentives to have low complexity procedures done in more costly facilities. Limiting a small set of prices simply leaves space for compensating increases in other prices. But limiting and rationalizing does not always mean decreasing. We may want to increase specific rates at the same time that we're putting stronger limits on prices that have gotten far out of control. The key is creating a system that sufficiently compensates providers for the reasonable costs associated with delivering a given service. For example, supply shortages and other financial concerns might lead us to boost some payments for primary care and rural providers. Also in this category, I'd place the development of a system that allows us to monitor, identify, and adjust payments for evidence of inappropriate levels of coding that increase revenue for providers and middlemen without increasing the value of services provided. The same goes for inappropriate increases in the volume of services provided. These strategies alone would decrease spending on many of the highest priced services and providers, reducing the market pricing power of highly consolidated providers, and would eliminate demand for a number of the profit-seeking middlemen we have described elsewhere, including repricers and IDR management firms. Also, in this first category, I place the development of a system to monitor healthcare delivery to catch as early as possible any access concerns that may arise from the new payment levels, including flexibility to adjust payments as necessary to correct any identified problems. I include this because it's important that we acknowledge that we don't know the ideal set of prices that would optimally balance cost, quality, and access nationwide. But acknowledging this shouldn't mean we don't use our experience, good judgment, and analysis to start working towards it. It means that some mistakes will surely be made, and we should structure our reforms to take that into account, look out for it, and give us the space to make adjustments as appropriate. Next slide. The second category of policies, prohibiting problematic financial relationships between stakeholders, would include an array of components. While not an exclusive list, these are strategies that I think would, together, have a substantial impact on disassembling the complex web. They include prohibiting common ownership across stakeholders, including separating insurers from providers, from middlemen, and also separating insurers from TPAs to eliminate cross-plan offsetting and other problematic practices and conflicts of interest. I prohibit TPAs from earning revenue from the array of hidden and misunderstood fees that currently characterize their income streams, limiting them to per member per month fees alone, and giving employers the ability to price compare across firms and creating actual competition. I prohibit anti-competitive contracting practices, such as requiring employers to use the TPA's chosen data warehouses or payment integrity firms, all or nothing provisions, and provider revenue neutrality agreements. Prohibiting shared savings agreements and other mechanisms for stakeholders to make side payback deals with one another, such as physicians receiving payments for sending patients to particular imaging facilities, or TPAs receiving fees from contracts they put in place with multiple point service solution vendors. A system for doing oversight and enforcement of these rules that includes auditing of stakeholder contracts is another important piece. Ideally, we'd also like to see the development of clean TPAs, such as quasi-governmental entities that pay providers at the recommended payment caps while eschewing all problematic financial relationships, limiting revenue to clear per member per month fees, and keeping its books and full array of contracts open for the highest levels of independent oversight. Next slide, please. The third set of policies, prohibitions on extractive practices commonly included in private equity healthcare deals, would include prohibiting high levels of debt financing in the purchase of healthcare practices and facilities, prohibiting the loading of purchase debt back onto the entity being purchased, prohibiting a single firm from owning conflicted entities, similar to the separation of ownership across stakeholders I mentioned before. Sale-leaseback transactions should also be prohibited. These are practices where a firm buys a hospital, sells the land on which it sits, and keeps the ensuing purchase price for itself, thus requiring the hospital to pay rent to another entity in order to continue operation. Another financial practice that should be eliminated is the creation of management service organizations, wherein the firm that purchases a healthcare facility creates an MSO and then requires the facility to pay that MSO high fees to manage the facility or practice. All of these practices make the providers financially vulnerable and redirect resources away from necessary patient care. Similarly, low staff to patient ratio should be prohibited to avoid reductions in quality. And more broadly, we'd certainly benefit from an expansion of antitrust law that encompassed more transactions and was associated with greater resources devoted to enforcement of these laws. Obviously, we could spend the day talking about these types of reforms for hours, but for today, I just want you to begin to see that it's possible for us to address the financial waste and abuse that is already far too rampant in our current system, but that we need to be thinking about significant and varied systemic changes to provide us with a more rational system that would allow us to expand coverage and affordability in a sustainable manner. So with that, I'm going to hand the mic over to Karen Davenport, who will give us a sense of the types of steps that states have been taking that relate to the kinds of reforms I've just described. Karen?
Thank you, Linda, and good afternoon, everybody. So now that Linda's laid out the three types of reforms necessary to unravel the complex web of financial relationships driving up healthcare spending, I'm going to share some examples of these reforms in the wild. These examples are drawn from our ongoing 50-state review of state strategies to regulate or manage hospitals' market behavior, which you can find displayed in some really beautiful 50-state maps on the CHIR website. Um, I want to start my remarks by underscoring Linda's prescription for systemic reforms. The examples I'm going to share here have, in some cases, been components of wide-ranging legislation that addresses multiple dynamics driving healthcare spending, but more often they have been proposed and sometimes passed with as narrower solutions to particular problems, such as the collapse of a private equity-backed hospital network or rising costs within a state employee health insurance program. So on to our first set of examples on provider pricing, and the next slide, please. So looking at rational provider pricing, reference pricing in the commercial market, which typically caps commercial payments for hospital care at a percentage of Medicare's payment rate for these services, has generated significant interest at the state level. I won't dwell on Indiana's 2025 legislation, nor LD 2196, which is pending in Maine, since our upcoming panelists can describe these efforts much better than I can. Vermont also passed reference pricing legislation in 2025, which directs the Green Mountain Care Board to establish payment caps for hospital services based on a percentage of Medicare rates by 2027 for commercial payers. Current legislation in Vermont, which has passed the state Senate and is pending in the House, would create some additional requirements for hospitals and health plans, such as requiring hospitals to obtain unique national provider identifiers for off-campus HOPDs to facilitate implementation and monitoring of reference pricing. And importantly, it would also establish the price cap at 250% of Medicare payment in state statute. Pending legislation in Delaware would also cap provider payments at 250% of Medicare rates for insurers covering more than 5,000 members and within the state employee benefits program. And speaking of state employee benefits programs, a number of states have adopted reference pricing within their SEHPs. This quick overview will touch on some of the states that use this approach. Working west to east, Oregon has used reference pricing for hospital services within their SEHP since 2019-2020, using 200% of Medicare rates for in-network hospitals and 185% of Medicare for out-of-network hospitals. One study found that the state saved $107 million in the first 2 years of the reference pricing program. Washington State's recently passed policy follows Oregon's structure for hospital payment and also establishes a payment floor of 150% of Medicare rates for primary care and behavioral health services. An SEHP, I see the question stands for State Employee Health Program. The Oklahoma and South Carolina are a little different because they directly manage their own contracts with providers rather than contracting with a health plan or TPA to manage their SEHP program. This means they also set their own rates. Both states establish their fee schedules at a point that is between Medicare rates and prevailing commercial rates in the state. And finally, West Virginia recently codified reference pricing within its state employee health program for all services, and the reference amount of 110% of Medicare represented a payment increase for some hospitals in the state. I should note that 110% is a floor on average across all services, but in practice, total payments average only slightly above this floor. Lastly, site-neutral payment proposals for ambulatory care, which would require the same payment for services regardless of whether the patient receives care in a hospital outpatient department or an ambulatory surgical center or a physician's office, seek to bring greater rationality to payment for outpatient care. Pending legislation in New York would cap commercial payment for a defined set of outpatient services in all settings at 150% of Medicare's non-hospital payment rate. That is the physician fee schedule or the ASC rate, depending on the service. If you are interested in more information on site-neutral payment, CHIR released just yesterday a comprehensive framework on site-neutral payment for outpatient services, which you can find on our website. Next slide, please. So Linda's paper provided a lot of examples of how problematic financial interrelationships between stakeholders drive up spending. And a few minutes ago, she offered a lot of great ideas on how to limit these relationships. Our research hasn't surfaced examples that bring many of these ideas to life other than prohibitions on anti-competitive contracting practices. These practices limit an insurance plan's ability when you're looking at anti-competitive contracts between insurers and hospitals. But they limit an insurance plan's ability to encourage the use of high-value, low-cost providers. For example, the insurer might need to contract with all sites and providers within a health system in order to contract with a single must-have facility and have that facility within its network. Or anti-tiering and anti-steering clauses could limit the plan from using provider tiers and consumer-facing financial incentives to encourage patients to use lower-cost providers. 22 states, at least 22 states, I should say, data is as of last fall, have enacted prohibitions on anti-competitive contracting practices, most often targeting most favored nation clauses. These contract provisions guarantee that the insurer will receive the lowest reimbursement rate that the healthcare provider offers to any other insurer. A practice that can stifle competition, for example, by ensuring that rival payers can't enter the market with lower payment rates and therefore lower premiums, or by encouraging price collusion between dominant insurers and dominant providers. Next slide, please. Finally, Linda's third bucket of reforms targets private equity's extractive practices, which can leave hospital systems burdened with unmanageable debt while creating huge payouts for private equity investors. With the recent bankruptcy and sell-off of the Prospect and Steward hospital systems and growing concerns about private equity's role in the healthcare system, there's been significant state activity in this area, including legislation that would prohibit sale-leaseback arrangements, which, as Linda noted, happen when investors sell the real estate that that hospitals sit on and own to real estate investment trusts. The investors collect the cash, and the hospitals face large lease payments to continue occupying the property they once owned. Massachusetts recently passed a prohibition on sale leasebacks, and legislation is pending in at least Maine, Connecticut, and Pennsylvania. New review authority or more intensive review requirements for healthcare transactions involving private equity companies, hedge funds, and/or management service organizations. California recently passed such expanded authority, and Maine just this week, as I'm sure Meg will share more with us. And then legislation is pending elsewhere, such as New York, Connecticut, and Illinois. Greater transparency about private equity ownership of healthcare facilities, which has been enacted in Massachusetts and is proposed in Connecticut. Vermont has pending legislation that would prohibit the payment of debt-financed dividends to private equity investors, a practice that loads debt on hospitals without investing the proceeds of the loans in the facility. And finally, the Virginia legislature, on a much lower level of intervention, is considering a bill that would create a state work group to study the role of private equity in a state's healthcare delivery system. I hope this quick tour through the states gives you some feel for how state policymakers are responding to healthcare cost concerns and how these approaches begin to unravel the complex web. And with that, I'll turn the show back to Sabrina.
Thank you, Karen. That was great, a great overview. And now we're going to hear from our two state leaders, Gloria and Meg. Gloria, I'll start with you if that's all right. Can you tell me a little bit about Indiana's experience with affordability-focused reforms? What is the state doing, and what was behind the state's decision to focus on affordability?
Well, thank you so much for inviting me to be here today. It's really a pleasure to be back. You know, affordability is a top concern for Hoosiers and Americans across the country, and that's why it's a focus of ours. It's our number one focus. I work as Secretary for Health and Family Services for the governor and as a cabinet secretary. So he tells me just fix healthcare, across the state. So when I think about how we're going to do it, we've spent many years talking about transparency and really focusing on transparency. And transparency provides really good information, right? As long as the methods are sound. But transparency in and of itself, as has well understood now. People used to say, "Oh, just make it transparent, and they'll be shamed into lowering their prices." But they're unshameable. Like nobody cares. So we have to regulate. So what we've been doing is really regulating prices because every year they just keep going higher and higher and higher. And so a couple of things that we've been doing, I'd say, is we've been focusing on regulation. So just in 2025, we passed 10 bills. Some of them have numerous components to it. So I'll just highlight a few things. But House Enrolled Act 1003 was on site neutral payments, as you mentioned, but it's kind of like that CMS definition. If it's off campus, if it's off of a hospital's campus more than 250 yards, they can't charge a hospital facility for it, a facility fee for it. And we passed that a couple of years ago, but then there were all these ways that they were working around it. So we tightened it down and really tightened it down last session. So we said which place of service codes you could use, which ones you can't. You can't request to be kept whole, which is something that the hospitals, largest hospital systems were saying with the insurance company was, well, we signed a contract. So even though we can't charge facility fees, you have to keep us financially whole, which means whatever we were getting for facility fee plus professional fee, you have to pay us that whole amount on the professional fee side. So, we stopped all of that nonsense last year. So I was really happy to see that. Audits, we also tried to get audits done, make it pretty tight a couple of years ago. We had to make it extra tight now. As everyone probably knows, towards an end of a session, you will oftentimes have like little poison pills that get, put into things and try to weaken language. And so we were able to tighten all of our language back up so that it's not like you have to respond to an employer's request for an audit to provide the 835 and 837 electronic file claims transactions. You actually, because the response was, thank you, we received your request and we'll get back to you. That literally was the response. And they still weren't getting the information. So now they have to provide it within 15 days of a request. We just went deeper into that audit space. The purchasers of healthcare have a right to have all of their own data. And so because they have a fiduciary responsibility, right, to make sure it's being used appropriately. So one thing that I was kind of excited about was a direct to employer. We required all of the big five, we call them the big five, but they basically have over 2 billion in net patient revenue. We don't like line item them in statute like these specific hospital systems, but we do a dollar amount. So if you're over this dollar amount, then you have to offer a direct to employer contract less than or equal to 260% of Medicare on the facility fee side. Does not include professional fee. So that was really important to us because the insurance companies just suck billions of dollars out of the healthcare system, as you well know, as leading CHIR. So we are like, how can we get, the hospital association is probably the one thing we agree with them on is that direct to employer is a good opportunity for both employers and the state employee health plan and as well as the hospitals. So we just did an audit. The audit results are not public, but I'll share with you that the large five all came in under 260% of Medicare. So then our next step and that should be public, I think, next week. But, our next step is, and we have employers and the Employers Forum of Indiana and other, Indiana Manufacturing and such, and all these other employer groups where they are trying to get all of their information and making sure it, that they really are going to be able to ink it, or are they trying to ink it just 250% of Medicare just for labs, instead of for everything. So we'll see if there are any games that we have to lock in. Competition is really important. So we talk about regulation, but prices and competition, right? So in trying to increase competition, we banned physician non-competes. We did it a little bit a couple of years ago. Last year, we applied it to all physicians, not just primary care. And we initially had a physician tax credit, like if they wanted to quit the hospital system or private equity and go start up their own private practice group. Here's a tax credit that you could get. So it's $20,000 a year for 3 years, just for primary care. And now we expanded that to all physicians. And those were just a couple of ideas. I think from an affordability perspective, we've done a lot in the PBM space and in the TPA space as well. And that was a big focus of ours. But, in the interest of time, I'll just name one. And it's, if we can all shop for care, you can go on Amazon, and if you know what you're looking for this size boot or wrap, or, a device for your knee to keep it stable. If you know what you're looking for, you might be able to find it cheaper. And so now if you do find it cheaper than usual medical care, that would be for your particular plan, it's required by law now to have it apply towards your deductible. So it encourages people to shop for care. Otherwise, why shop? What is the point of all of this transparency? If they can find the drug on Trump RX or Mark Cuban Cost Plus Pharmacy or Lilly Direct, or, I'm not, no affiliation with any of them, but, just saying that there are more and more people are getting into this space. If they can find the best price, even if they're not in network, even if they're out of network, they should be rewarded for that. So I'll pause there and,
that was a
turn it over to
great,
Meg.
yeah, that's a lot going on, Gloria. But I'll turn it out to Meg and ask Meg what started Maine on the affordability journey.
Yeah, absolutely. And thanks. Great to be here, Sabrina. I've benefited a lot from the publications and the prior webinars associated with this project. So excited to be here today. I'll jump in a little with the background. Just to start by saying, before I stepped into this role with the Office of Affordable Healthcare about 3 years ago, I was running our state's state marketplace for health insurance. So every day I was seeing and interacting with people who were struggling to afford their health insurance. And I was looking for anything that we could do to improve that. And given that role was really focused on insurance regulation. So I think we innovated and tried a lot of different things at the insurance level to work on solving those problems. But what I learned and saw, kind of digging into rate filings and other data, was I didn't feel that there was anything we were going to do just at the insurance level that was going to overcome just the increasing cost of claims that we were seeing that was being passed through to consumers. So when I came into this role, I was really excited to dig in deeper on those issues, to understand the data and to look for solutions there, and was really glad to find that our consumer advocates were also interested in that, and our purchaser advocates were. So it was natural for us to kind of focus in this area. In terms of immediate priorities, we had a couple that we started with. The first of those was this issue of financialization in healthcare. It's been less prevalent in Maine. We haven't had a situation here like a crisis for a hospital or health system, but we saw that happening in neighboring states. And I think there was a real interest among policymakers here in saying, can we stop that from happening in Maine? What can we do to actually be proactive and preventative? So last year, we worked on a bill that made changes to our state's review of transactions here. We do have a certificate of need program, but it's quite narrow. It focuses only on the largest transactions and only a few factors. So this was a much more comprehensive review based on a program in Oregon, but with some changes to make it more focused on Maine, that would let us look at more transactions and more factors, like what's the impact on affordability and access for consumers and other risks. That's been considered by the legislature, and through that process, it has been narrowed quite a bit. So it does now focus just on private equity transactions, so acquisitions or transfers of control that include a private equity company or an MSO with private equity backing. So narrower focus, but still a big step forward. And as I think Karen may have referenced, that actually passed our legislature unanimously just yesterday. So some breaking news there, but it's really an effort that there was a lot of interest from bipartisan legislators in. So a success there, and we're looking forward to turning to implementation on that this spring and summer. The other effort that we really wanted to focus on, that we saw as a big part of the root of this issue, and probably the most direct way where we could actually have an impact for consumers and actually provide some relief to them, is in the price regulation space. So we also proposed a bill just this session that the original form of it included a cap on the prices that hospitals can charge for facility services that was pegged to Medicare rates. So a multiple of hundreds of what Medicare charges for or pays for those services would be a cap on what commercial payers would be charged by hospitals. It it paired that service level cap on the prices themselves that actually would have brought down the highest prices with a cap on the growth of prices. So commercial prices could only grow annually for hospital services at the same rate that, again, Medicare increases payment each year, that reflects more what the actual increases in input costs are, because we identified that just the growth in hospital spending and prices was outpacing inflation and all these other factors in a way that clearly was impacting affordability. The original version of the bill also included some reforms to prior authorization. That was something that we heard from hospitals was a driver of those prices. So we said, great, let's try to reduce some of that administrative burden for you by reducing how often insurers can apply prior authorization, essentially. And we also included floors on payment from commercial payers for primary care and behavioral health care. Just like we see these very high prices for hospital services in our data, we also see that commercial payers, especially for mental and behavioral health care, are often paying even less than what Medicaid and Medicare are paying. So we wanted to say, let's, take from the top essentially and invest some of those savings in these kind of upstream services that people really need and where there are access challenges. So similarly, that bill also was kind of changed through the legislative process and narrowed, and right now includes only caps on the growth of hospital prices and applies those more narrowly to the small group individual market and the state employee health plan. It removed the prior authorization changes since those, we needed to think about kind of offsetting costs, but kept in the floors for primary care and behavioral health. So that did pass out of our Health and Human Services Committee with an ought to pass recommendation, but still pending now in the later days of our session. So that's what we've been up to in Maine.
Thank you, Meg. I'll ask you both now, and maybe I'll start with you, Meg. What lessons have you learned from your work on these policies?
It's a great one. I will start by saying, if you embark on any of this at a state level, expect to face some real pushback. I think, folks will say, oh, well, maybe starting small, is a little bit easier. Maybe that'll face less pushback. In my experience, I think this is a new realm of policy, and some of the industry folks who have previously not been touched much by state legislation, maybe haven't had a lot of focus on them in terms of what their role in affordability might be, really want to hold a line and say, like, don't look over here. We don't want any scrutiny. So even things like that transaction review, where we were only thinking about the future, it wasn't a prohibition on anything. It was just a little bit more transparency and visibility and some ability for the state to weigh in, got a very, very strong reaction. So that's one lesson learned, and just kind of a warning for others, but also you're not in alone if you experience that. But another for me has also been the value, I think, of kind of coalition building in this space. And again, that it might not be as natural a fit. And I think for consumer groups, for example, they may have historically been focused a lot on some other issues, including insurance reform. But I think purchasers, employer purchasers, and consumer groups both see, and if they're not already working on this, I think chatting through kind of the data and evidence with them can get them really engaged. And we found that being able to have a broad, strong coalition of the people actually paying for the healthcare is sort of the one way to hopefully effectively counter some of that kind of industry side pushback that you'll inevitably receive if you start heading in this direction.
Thank you, Meg. Gloria, what are the major lessons you feel like you've
I would
learned?
I would echo everything Meg said. It is really, folks are just full of bluster and bare on facts. And, more pointedly, people just lie. And they will do and say anything to win. And I'm talking about the industry in the middle, like all the middle people, the PBMs, the TPAs, and the hospitals are not necessarily the middle people, but they'll come up with their own studies, and they're all like, it will only have a quarter of the hospitals in there, and they won't tell you which hospitals they were. They could be just the critical access hospitals, but you don't even know. So it is just endless. And they will attack you, the research, the researchers, and everything in between. So it's fine. The lesson is everything we do is evidence-based. It's transparent. Everything's hyperlinked. We don't have hundreds of lobbyists at the State House trying to tear everything we're doing down, but we have the facts on our side. Another lesson that Meg touched on is the facts alone are not enough. You really need to have coalition building. in there. And so, who are your allies? Different business groups, but not just the business groups. Sometimes it is, yeah, consumer groups, right? They are the beneficiaries of healthcare. And then organizations such as yourself, the National Academy for State Health Policy, Brown University, Berkeley, like all these folks have testified for us in support of their own research. But just them defending their own research is very helpful at the state level. So we need everybody. We need the research. We need the analyses. We need, policy wonks to put all the policy together. And then we need people that can explain it in plain English, at the fifth grade level as well. And then the other piece that we really need is you have to have someone that is politically respected and influential, helping carry the message. That's, I can't emphasize that point enough. It's easy to be like, oh, they're funded by blah, 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 and those people are in part of the deep state, whatever that means. But, everything can be, everything you say is going to be challenged. So just if you can create that echo chamber across different stakeholders, that really does help.
This sounds like great advice that hopefully many of our audience will take back to their state capitals and advocates and legislatures. I think it's now time to turn to audience Q&A. So I'll ask Linda and Karen to turn their cameras back on. And we've already got a number of questions in the Q&A box, and I will just remind folks you can submit a question at any time by clicking on the Q&A box on the bottom of your screen. I will start. I think this first one might be for you, Linda. It asks if you could speak to how you see the difference between old school integrated systems and the current vertical integration that we're seeing. I assume by old school, we're talking about things like Kaiser or Geisinger, maybe.
Sure. Yeah, it's a good question, because when we look at a system like Kaiser, there is a different culture and a different set of objectives there. That is a system where frequently, not always, but frequently Kaiser owns the hospitals in which the patients are being seen, and they're also employing the physicians that are seeing the patients, and they are the insurer, and Kaiser is the insurer. And the difference here is that there is a capitation payment that's made, right, that people are comparing based on to other types of insurance that's including all of these services, and those dollars are being split up across the different components, whereas they've got to stay within that capitation, and they're all they have their incentive to be efficient in terms of the care that's being provided in order to stay within those capitation payments. And what we're seeing with these other entities, and especially, and self-insuring employers is a really easy place to see this, right? A self-insuring employer will basically open an account that their TPA that's administering the plan for them is drawing money out of, right? And in our current system, for example, the employer doesn't even know how much money is being drawn down to pay for claims versus how much is going to fees that are being paid to middlemen and intermediaries. They don't know how much the dollars are being, in payback amounts are coming back to the TPA in a whole assortment of fees. They have no idea how much money is going where, right? And so there is a tremendous amount of leakage and incentive to increase the spending, right? So the prices that are being paid by to the providers are being increased by the fees that those providers have to pay to their middlemen who are interacting with the insurers. So there is so much more space in these newer dynamics for huge increases in spending, whereas the incentives in the old line, the Geisinger type of model is towards efficiency and more clear provision of care for a capitated payment.
Great. Thank you, Linda. I think this next one is Gloria for you. An audience member is asking how you determined the 260 percentile of Medicare. Like, how did you arrive at that level of payment?
Yeah, sure. That's a fair question. So when we looked at the RAND hospital price transparency studies, which looked at over 4,000 hospitals, and the RAND 5.1 study. So there's 5.0, they made some tweaks. So 5.1, and it's posted on the RAND. If you just Google RAND hospital price transparency, you'll get to all of their reports. But the average was 254%. The national average was 254%, and they just kind of rounded up. So Indiana was sitting at around 300%. And so that's how we got to the number of 260.
Okay. Thank you. Meg, I'm going to throw this question to you. What recommendations would you have for state staff in a jurisdiction where employers are not organized and where the financial struggle of some hospitals, i.e. the have-nots, dominates policy considerations? And Gloria, you should also feel free to weigh in on this too.
Great. Yeah, I'm happy to speak to the second part, the hospital part. I think Secretary Sachdev might have better advice in terms of engaging employers because, like I said, we were very lucky to have an engaged coalition here. On the hospital side, that's been a big challenge for us. In Maine, we do have all nonprofit hospitals, and we do genuinely have some rural hospitals, some mid-sized hospitals that are genuinely financially struggling, and not the same volume or number of hospitals as some larger states that are, maybe exceeding 10% operating margins each year. It is a different landscape here than in some other states. And that creates different challenges and I think different messaging that's needed. I think we've been careful here never to pose this as an issue of sort of greed or hospitals trying to take this money for their own purposes, but really just kind of talk about working together and how the system is really problematic for everyone involved, and to some extent actually allowing for the system that we have now where market power really dominates what prices are being demanded isn't great for hospitals that are struggling. That working towards a system in which we pay what we think those services are worth is a way to sustain services in rural areas where a simple kind of economic demand model isn't effective. So that was important for us. And then the other piece that we've been working through, and I think there's still more work to do here, but this is something I'd love to engage with folks on, so I'll throw it out there, is talking about ways that hospitals can kind of operate more efficiently. That's an area where there's less research and I think maybe more work to be done, but thinking about that in simple ways, but also collaborative ways. And where can the state kind of lead potentially on changing what service delivery looks like to, again, be more efficient and provide care in a different way. So that's something we didn't touch as much on. Our office is involved in our Rural Health Transformation Program funding, and that's a big goal of that work, is to think about some of this and kind of getting to a place where there is a more rational system of both payment and care. So more work to be done there. But that'd be my advice on that section, and happy to have the secretary weigh in if she has thoughts on engaging with employers.
Yeah, so prior to this job, for those that that don't know, I ran the Employers Forum of Indiana for 10 years as their president and CEO. So interestingly, the Employers Forum has been, they just recently did an analysis to look at all the hospitals in the state, and they went to their Medicare cost reports, look at their 990s, and really did a deep dive into the finances of all the hospitals. And what they found was, surprisingly, that as you pointed out, Sabrina, that we have about a third of our hospitals are actually on, barely breaking even or negative margins, like truly. Okay. And these are mainly in our rural areas. And so as Meg said, we are, and I'm happy to get into that if there's interest, but we're using our rural health transformation dollars, which we got $207 million from CMS to work on that. I think every state got money. So it's an opportunity for every state to consider about how to fix rural healthcare. Our hospitals that are in the lower margins are in the rural areas. They are not our other hospitals. That's not to say that couldn't be the case in some other states. We have about a third that are in the, 5% range, and then we have about a third that are over double digit in the double digit area. So it isn't a one size fits all. You can't just do these big hammer type of solutions. That's not really what, and most of our policies, when you go and we exempt critical access, rural health, FQHCs, CMHCs, all that. We're not trying to, we want competition. We don't want them to close. One thing that's been kind of sad for me, and I would love to hear if anyone in the audience or you have ideas on, is we have had a lot of OB closures. And, people, you hear, oh, we don't pay them up. It's hard to get OBs in here. But it just seems so extreme. Like we've got to work on this. We've had 19 delivery service areas close in the state since 2017, 15 of them since 2020. So for me, I'm like, okay, you need to use these rural health transformation dollars and figure out how we're going to provide access to care. I mean, affordability is really important, right? We talked about that, and we talked about competition. But we also need to talk about access is all part of that. If we lose another 15 in the next 5 years, I mean, what young families kind of coming here, right? That really hurts our economy. That's our working population. So it's something, I don't think it's unique to Indiana. It's happening across the country. Is it truly, and we have people doing surveys for our market, is it truly because we are paying OBs so poorly? We've looked at some places to say, okay, well, people are just voting with their wheels, if you will. They're driving further to go to a larger hospital system than to a rural place. But curious if anyone has any comments or thoughts on OB delivery services.
That's a great question. And I would encourage folks, if they have thoughts or comments, to put those in the chat, but put your questions in the Q&A box. We got a question that I think I'll throw to you, Karen, which is this. Dr. Blumberg emphasized the need for systemic reform. We haven't seen a whole lot of that yet. It's really hard to do. Do you have any sense of whether there are certain state level policies that are working better than others?
That is a great question. And I think my mind goes to places like Oregon and Massachusetts, where they have been building a mosaic of a range of reforms. And Indiana obviously has been on an accelerated pace to, similarly build that mosaic in the last couple of years. I think, that evidence isn't complete for any of those states in terms of how well, the suite of reforms is controlling costs, but, also looking at California and how they are more aggressively implementing their cost growth benchmark. I think there are pieces to learn from multiple states, but if you look at a state like Oregon, which has reform transactions and has created reference-based pricing in their SEHP and has, taken other steps that I think those are some of the places to look at. Like, what are the combination of policies that they are implementing and how are those working? And I think we'll learn a lot from Indiana in the next few years as their reforms all come fully online.
Yeah, I was just going to say that. I feel like Indiana's been where the action is lately, Gloria.
Yeah, we're a stubborn group. I mean, it's like we will, but honestly, it doesn't happen without all the champions across the country that have been helping us as well. And in our state, I give our legislators a lot of credit. They are just not having it anymore. They are done because the industry's been caught in their lies. And the PBMs say all this stuff when they testify. All I have to do is just gather my little 1 sheet or 2 sheeter and pass it out to everyone. Everything's hyperlinked and they have the facts in front of them. Or we hire people, partner with people just to provide the evidence and the data. So we want transparency. I'm thinking about just going old school now. I'm tired of all of the shenanigans. We're still going to fight the fight, but part of it is we just need to kind of go to cash prices. I really like that, the Mark Cuban Cost Plus model. Why can't we have that for all of healthcare? Why can't we just have a cash platform everywhere? So we're in process of trying to build one now. That will probably launch here pretty soon. And it's just going to have cash prices. And it's not like, oh, if you have this insurance and that insurance, and if you're this, that, it's just all of the nonsense that is our current health system. I'm not sure we really need insurance companies or PBMs. They just need to go back to what they were, which was processing claims. I'm sure my inbox will be full later, but that's fine. That's just how I feel.
I think you are reflecting the frustration that a lot of people feel. We have time for just one more question, and while I recognize that this conversation has been really state focused, we got an interesting one in the Q&A box that I think I will throw to Linda. And this is a question that points out that Uncle Sam, and I think by this the person means the federal government, is the largest employer in the United States and has several million employees, retirees. Has Uncle Sam, or OPM, that's the Office of Personnel Management, shown any interest in helping to attack this huge problem? And Linda, I'm throwing it to you. I don't know if you have any insights into whether the federal employee health benefits program is an innovator at all in this space.
I certainly feel that the federal employees health benefit plan could be an innovator in this space. I would love to use it as an incubator, right? As Karen has talked about and others have mentioned, there are a number of states that have used their state employee health benefit plans to try to implement reference pricing and various different kinds of strategies. The FEHBP is so much larger than these state employee plans. It stretches all the way across the country. There's a lot of competitors in that as a market. And I feel like we could use it as an incubator to test a number of these kinds of strategies. I'd love to see it. I have not heard of there being any motivation or interest in doing that from the higher ups, but it's definitely something that I would love to explore, because the other piece of that is that they have a lot of potential control over their data, and so allowing us to measure what kinds of impacts would be, I think, potentially a lot easier there as it is with state employee health programs.
Well, that unfortunately is going to have to do it for us. We are at the close. I just want to thank our panelists and thank our audience. We have learned so much from all of you today. We could not have had this conversation without the wisdom and expertise of Linda, Karen, Gloria, and Meg. As I mentioned at the start, we'll be sending a recording of this webinar to everyone who registered and posting it to our events page. We got so many questions in the chat. I unfortunately was not able to keep up with all of them, but we will be happy to try to answer questions via email or offline if people want to reach out. Also, if you're interested in learning more, we will be having a public event here in the DC area. So we will be sending invitations to that event, which is approaching May 19th. Before you sign off, please take a moment to fill out the very short survey that will pop up on your screen. Your feedback is really helpful to us in designing these webinars. Thank you so much, and wish you all a wonderful weekend.
Thank you.